I would like to invite Dr. Kumar Doctor, who is the director of the Kumar Eye Institute, Dr. Kumar Eye Institute at Mumbai, and again a cataract refractive surgeon with a pioneer in refractive surgery and a lot more. On to you, Kumar.
Thank you. I'm just going to show one case, a decentered femtoflap. So you can see it's beautifully decentered. The hinge is in the middle of the pupil, and I managed to even bleed the conjunctiva. So why did this happen? We'll discuss later. But if this happens, what to do is what I'm going to show. So it can happen. It's just basically, this was a very old video, must be about 9 years back. My initial femto cases, that's bottom line here is to understand the technology that we buy, and if that gets a slip somewhere, this can happen. So in case this happens, we have two options. One is to do a recut the same day, but my inexperience made me wait that time, and I let the patient go home and then call back. These bubbles, I don't know how many of you know that these bubbles disappear in 45 minutes. You won't see anything there at all, and you know where your hinge is. So very important in this case is to know what was your targeted flap depth. And those times we were not having so much of corneal OCT. But today's era of corneal OCT, we will actually know exactly. I may have targeted a 190 micron or 100 micron, but it may create a 95 micron. So doing a corneal OCT maybe after a week or so and get the idea what it is. So one is, now I want to recut. Okay, so I'm using the same system, getting a little more wiser. This is a Zimmer and this was a Z4. Now I have a Z8. Okay, so now I'm going to make a flap, and it makes a flap. So now very important is the flap has to be made deeper than your original targeted flap by about 15 to 20 microns, and it's pretty accurate. So if you remember, my original flap was here, so I'm not going to lift anything here. When I make a new flap, I'm going to just make sure that I lift from the area where my original flap was not there. So once I get that plane, I'm all sorted. So you can see that I never entered in the area where my original flap was made, and this, you get a beautiful flap now. I've gone 20 microns deeper, and you will see a little circle of the original flap that was there. Sometimes these bridges may interfere in your dissection, but otherwise it's pretty smooth, and you can see a little bit of a hinge kind of a thing here, but otherwise you can see a smooth corneal surface, and this gives excellent results. So that is one thing that I would like to say, and then of course you go ahead and do your ablation and do everything is fine, and everything is fine. Now I'm going to show you one more case. Okay, now this was in some times back, we also used to do patients who had RK, and we'll still go ahead and do a LASIK flap on that. This I did, and this was not a many cut RK. Okay, now what happened is the patient, we do put a contact lens in these patients. The patient fell asleep in the afternoon, suddenly got up with severe pain. So in my experience, when a patient says severe pain, means he's done something to the flap. This is what I have found out, a correlation between history and findings. So now this you can see is a 8 cut RK, came back with severe pain the same afternoon. Okay, so now the epithelium heals by evening. Many times you might notice this, that the epithelium has healed by evening, but as you see, the RK flap is now torn into two pieces involving the visual axis. Okay, don't worry friends, even if this happens, excellent results. I have not done anything very high tech from what you might have read, thought, and this thing here, what I'm going to show is the epithelialization that happens on the surface. Make sure that the epithelium is removed. The back surface of the epithelium, the stromal flap which is cut, is also cleaned. The other edge is also clean. So now you can see that you don't need to worry about right side up or left side up, okay, because the RK marks themselves, when you align, is the right orientation of the flap. So you don't have to worry stromal side up or epithelial side up. That's not an issue here at all. Now the question here was, do you need to suture this or you don't need to suture this? You'll be surprised if you get something like this, you really don't need to suture it. Okay, I did this, and patient's doing extremely well. I'll show you the post-op results too. And here you can see that I put the flap back, and all the marks, which are the RK marks, are beautifully aligned. The question here, when you see that this is going through the visual axis, will it leave a scar? Will there be epithelial ingrowth, etc., etc., etc.? And you'll be surprised that nothing happens. Okay, there is really nothing to worry. This heals beautifully, and if you see this the next day, you really don't see anything. But you have to spend that little extra time to align it, to make sure that the epithelial edges are all gone. And once you cleaned it up completely, I'll show you the picture first day post-op. We do put a contact lens again, and you can see on slit lamp that the central visual axis is completely clear. So this is a result that you can achieve. You don't have to panic, nothing really happens, but of course the patient has to be told to be careful and not rub the eye again. So these two cases I had
Thanks
to
a
show.
lot.
Thank you.
Yeah, and thank you very much. Connect the thing. I'm sorry for rushing you, Kumar. He came running, so I wanted him to present. One question to you, Dr. Sri Ganesh. If you had a case of suction loss, I've asked you earlier, I think, suction loss in smile, would you advise that you wait for the OBL to settle down, or would you proceed immediately? What would be the main thing you would confirm, even if you're going to do it with the OBL there?
Basically, you can immediately redock, and because you have your bubble layer there, which acts as a guide for centration. But when the bubble layer is there, the patient cannot fixate at the green light. So you just massage the center, and so that you push the bubbles to one side, and the patient is able to see the green light. And then you have your circles in the reticule, which you can kind of correspond to concentrically to the bubble pattern, and then redock. If you have any black spots in the center,
then you should wait.
Then you do not do smile. Either you wait, postpone, and then you can do a smile at a deeper level, or you can do surface ablation.
Thank